first speaker today, and that's the lovely Kylie Tastula. She's a mover and a shaker at RPA, and if you were to go in there to do for a stroke, it is Kylie and her wonderful staff that you're likely to meet up with. But not only that, she's been involved in ACI, the Agency for Clinical Innovations, looking at best practice to be basically thread throughout New South Wales in the stroke units and the stroke services. She's also involved with the Ministry of Health on the Clinical Council. So Kylie is a wealth of knowledge in this area. It's a new area that we're exploring today. It's about the assisted dying laws that came in New South Wales last year. And while it may not specifically be relevant to stroke as such, it's relevant to all of us, I think, who are, one, getting older, or who may in some time be faced with some catastrophic illness or decision that we have to make in regards to our future. So I'm looking forward to hearing Kylie's presentation, and I now introduce you to Miss Kylie Tastula.
So I am going to start by thanking you, Michelle, for inviting me to talk today. And this is a very different topic for me and for you guys. So I will start by saying it probably can be very triggering and very emotional for people. So I do have some support lines and things if people want to reach out, if they have got any concerns during the talk. And also you can come and chat to one of us if you are at all worried. I have been told about 5 times to make sure I speak slowly today, so if I'm talking too fast, feel free to wave and tell me to slow down at any point. So some of you may or may not be aware, but the legislation came to New South Wales in 2022. So in May 2022, the Voluntary Assisted Dying Act was passed in New South Wales. We are probably one of the last states to actually implement the Voluntary Assisted Dying rules. But it is basically meant to try and give people a choice. It doesn't impact the majority of people, as Michelle said. It's not necessarily anything to do with stroke, but it does impact some people at some point in their lifetime. So what the principles, this is really hard when I can't read my own slides. What the principles actually sort of talk about, is there a microphone that I can use or a laptop? Okay, I'm going to walk. Okay, so what the principles of the Act, basically what they say is that every human life has a value and everyone should have some choice around what that life looks like. Everyone has their own individual autonomy and their own ability to choose how they want to live and die, basically. Everyone has the right to be supported to make their own medical decisions. So I think it's something that we're trying to challenge a lot in medical care at the moment. It traditionally has always been that doctors make a lot of the decisions around what happens to people. This is meant to be giving you as much choice as anyone else in that decision making. Well, this is actually more choice than anyone else in that decision making. Anyone who's approaching their end of their life should be treated with respect and with dignity. And the relationships between your treating doctor and the end of life care, that relationship should be maintained throughout your lifespan. And I guess this is the big one. Death and dying should be spoken about openly. It's not necessarily a topic that people like dying about. My sister-in-law, my brother and sister-in-law have been together for about 20 plus years. Her first introduction to our family was apparently me banging on about organ donation. And that was the first thing that she can remember was a topic about death and dying at the dinner table. And I think it's something that more families should start talking about so everyone knows what people want. And the conversations within healthcare should be supported between people. Everyone's entitled to their own genuine choices, and your ethnicity, your culture, your religion, all of those influencing factors should be part of that decision making. One thing that is relevant in stroke and here is your postcode shouldn't matter. So no matter where you live, you should have available options to you. You should be protected from pressure and duress, and I think it was very similar to when organ donation first started. Everyone felt there was going to be a lot of pressure to donate organs and things. That is most certainly not the case here. And as I said, we need to respect everyone's culture, religion, beliefs, values, and personal choices. So there's lots of eligibility criteria to be eligible for voluntary assisted dying. So you need to be an adult, so you need to be over the age of 18 years of age, so children have no access to it at all. You need to be an Australian citizen or an Australian resident, or you need to have lived in the country for 3 continuous years to be eligible. And in New South Wales, you need to have been a resident of New South Wales for the previous 12 months. There is some exceptions around that. So if you live interstate but all of your family and all of your support is in New South Wales and you spent most of your life in New South Wales, they might grant you that, but it is done on a case-by-case basis. So at the moment you actually do need to be a resident in New South Wales to be eligible. To be clinically eligible, you need to have at least one disease or illness that fits the following criteria. And so it needs to be an advanced disease and it needs to be a progressive illness that will lead to your death. But your death on the balance of probabilities, so that's whether the treating doctor feels that you will die within 6 months. So it's from the 6 months from when you ask about voluntary assisted dying, you need to have a terminal illness that will probably cause you to die within 6 months. The exception for that is in neurodegenerative cases, that's 12 months. So if someone's got motor neuron disease or a disease like that, it's got 12 months from when their timer starts. It is also meant to cause you suffering that cannot be fixed in any way. So that suffering can be mental anguish, it can be emotional, it can be physical, it can be pain related, but anything that you feel is causing you enough anguish that you want to end your life. And that's based on your assessment. Obviously no one else has any say in that. You also, this is the big one, you have to be able to make your own decision. The decision for voluntary assisted dying, you have to have the mental capacity to make that decision. So if you decide one day that you want to have voluntary assisted dying and that within 2 weeks you lose that mental capacity, you're no longer eligible for it. So right up until the final day, you need to be able to have that full mental capacity to make that decision for yourself. And it is only a decision that you can make. No one else can make that on your behalf. So if you write yourself an advance care directive or a will, you can't write voluntary assisted dying into that. You actually have to be able to express that wish for yourself. It needs to be voluntary, so no one else can be talking on your behalf. You need to be able to do it for yourself. And you need to actually, there's reasonably specific words that you have to say that the healthcare practitioner knows that you want to assess voluntary assisted dying. So it can't just be, I want to die, you need to actually talk about the process itself. So we know that you are actually really clear in what you're asking for. Additionally, so people who have any form of dementia, a form of disability is not a reason for voluntary assisted dying. Anyone who's got dementia is not eligible for it, and anyone with a mental health impairment is not eligible for voluntary assisted dying. So as I said, you have to have your own capacity to make those decisions. So anyone that doesn't have that capacity can't make that decision. So the legislation sets out protections, and the protections are for everyone who's involved. So there are multiple ways that you can access voluntary assisted dying. So the healthcare team that are involved in that, they're protected from any laws for when the person dies, and the people who are around at the time are protected from those laws. As long as everyone is considered to act in good faith, then you're protected from all of the legislation. So, the process for voluntary assisted dying. So in New South Wales Health, there's actually a board that has been set up, and they're the ones who approve every single person's application for voluntary assisted dying. So there's 5 people who are appointed to that board, and every application, so once all the paperwork, everything has been done, the board goes through everyone who's applied, and they actually approve or not approve the process itself. So that includes those people who might not have residency in New South Wales. They might have been a permanent resident for however long. They actually look at all of those and they deem whether or not you'll be legally able to access voluntary assisted dying within New South Wales. So this looks long and confusing, but this is the actual process. So it initially starts, so if you want to access voluntary assisted dying, you can ask any healthcare professional about the process. So when I said at the beginning that there were principles involved and it has to respect everyone's religious, cultural backgrounds, etc. That also includes the healthcare professionals. So if healthcare professionals don't want to have any part in voluntary assisted dying, they do not need to. So it's completely an opt-in system. So you have to voluntarily want to participate in it. So if you approach someone who doesn't want to have anything to do with voluntary assisted dying, they can say no to you and they can tell you to go and approach someone else. So no one on both sides is forced into being part of the process. So if you decide that you want to talk about voluntary assisted dying, you would talk to your initial coordinating practitioner. So there's a whole bunch of training that has to happen for people to be a coordinating practitioner. So the first person goes through all of those clinical eligibilities. So they look at whether you live in New South Wales, whether you're of appropriate age, whether you have capacity to make those decisions, and whether your diagnosis will lead you to die within that 6 to 12 month time frame. So they look at all of those assessments. They might not be, so if you've got an illness of cancer is your diagnosis and you've been told by your oncologist that you're going to die, your oncologist might not be your coordinating practitioner. So they might refer you on to someone else to do that. And I think when it initially started, that was a lot of the concerns that a lot of the consultants had, was they've spent years treating these patients. They then found it hard to then transfer to talking about voluntary assisted dying. So there's other people who they might refer you on to then look at that process. So the coordinating practitioner goes through it all. They would then deem you what they consider to be eligible for voluntary assisted dying, and then they refer you to a second practitioner who then goes through and does the exact same thing to make sure that they believe that everything was correct from the first person has said. And if those two both say that you're eligible, it has to be done in writing, both by the person who's requesting voluntary assisted dying and the two healthcare practitioners. And so those written requests then get submitted to what we call the portal, and that board that was set up by New South Wales Health, they then assess every single person in terms of eligibility. So once you've got the two practitioners and the patients, all their written documentation, it then goes into the board to work out whether or not to do it. As I said, so you need to be an authorised voluntary assisted dying practitioner. So Sydney Local Health District, where I work, so they wanted people who worked in those areas. So they wanted people from oncology, they wanted from them from haematology. We actually employed a lot of GPs. So there's 5 GPs who are actually employed by Sydney Local Health District, and their job wholly and solely is voluntary assisted dying. So they sort of do the bulk of it with us. So you don't have to be an expert in that area to make those decisions. So if someone's got a terminal illness for cancer, it could be a GP that's making those decisions, but they base it on the reports from the oncologist and from everyone else. Okay, so it doesn't matter what their profession actually is, they can then work it out from that. So as I said, so they go through your clinical and your social eligibility, so where you live, are you of appropriate age? They will assess whether or not they think you're competent to make that decision. If there's any concerns about whether they're not sure whether you know whether you're making the decisions or not, they can refer you on to see a neuropsychologist to assess whether you are capable of making that decision. And a lot of the conversations at that point, people will involve family or they might not involve family, and a lot of it is looking to make sure there's no duress. So all the paperwork has to be signed by multiple witnesses at multiple different stages. None of the witnesses are allowed to be inheriting things on a will or anything like that. So it's always got to be people who are sort of a little bit more independent, so it doesn't feel like there's pressure from anyone. So the people who are doing that assessment make sure there's no duress and make sure there's not concerns that someone's being forced into making these decisions. As I said, the second one goes through and then it goes through the board to make that decision. Which way am I going? So how do we know when you die? So a lot of it talks about the balance of probabilities. So it's a clinical educated guess by the clinician. So as you all know, none of us can predict when someone's going to die. If someone comes into hospital, we don't have a glass ball that tells us someone's going to die at this particular time. So it's in their clinical experience, do they think you're going to die in that time frame? And there are reasonably strict criteria for who can actually be involved in voluntary assisted dying. So to be qualified to be a VAD authorised practitioner, you need to be a consultant of at least 10 years experience. So it's someone who has got a reasonable amount of experience. They need to have a specialist registration, so like an oncologist, a general practitioner, they need something. They can't be a family member of the patient, so if it's your family, you obviously need to step away and you can't have anything to do with the official process, and you can't be financially beneficial towards the person who's dying. You need to have, well, at least 5 years experience if you're a GP, and if you're an overseas practitioner, if you hold provisional registration, you might be. A nurse practitioner, so I've done the training, so we can be eligible for part of the process, not for the beginning part, so we can't determine eligibility, we come in towards the end of the process. So it is people who have got a lot of clinical experience. We all had to do a lot of training for voluntary assisted dying, so everyone who's involved in healthcare had to do the general training, so there's sort of general training around the rules, the eligibility, what it might look like for people in hospitals and things. But if you want to actually be a VAD practitioner, there was sort of an 8-hour face-to-face day that we all had to attend. There was some online modules to do, and then we all had to sit an exam at the end of the exam, and you had to pass the exam around all the legislation requirements and things before you're actually then considered an authorised practitioner. So in terms of what it means for Sydney Local Health District or for healthcare staff, I guess, it's our job to uphold the legislation. So whether we believe in it or whether we don't believe in it, we need to still give people access to that process. So if it's a healthcare clinician, so the neurology department I work in, none of them want to participate in voluntary assisted dying, but none of them can access patients access to that process. So if someone asks about it, they then need to go and get someone else who can actually be involved. It is, as I said, it's an opt-in, so a lot of staff will have the similar feelings to what the general population have, so it's voluntary who wants to participate, but we need to make sure that we offer all of the same process, the protocols, and everything is still available for everyone. And as I said, for our staff, just because it obviously takes a long time to get through the process, it's mostly GPs who are running it within Sydney Local Health District. A few of the big differences from New South Wales to other states when we introduced the laws was in New South Wales. So in other states, a healthcare professional is not allowed to offer voluntary assisted dying as part of their treatment. In New South Wales, we are actually allowed to offer it as long as it's done as part of a bigger conversation around end-of-life care. So as long as we offer palliative care and other options to you, we're allowed to actually speak about end-of-life. We're allowed to speak about voluntary assisted dying, but it can't be, we think you're going to die and the only thing we offer you is voluntary assisted dying, because obviously that would be undue pressure on everyone who's involved in it. So it has to be a part of a bigger conversation. So that's one of the biggest differences in New South Wales. So in terms of sort of practical aspects around voluntary assisted dying, obviously a diagnosis of a stroke is not a reason for voluntary assisted dying. It doesn't preclude you if you get other diseases after you've survived your stroke, and I guess being aphasic is one of the biggest concerns because you need to be able to verbalise this for yourself. But being able to verbalise it, you can actually, if you can communicate in writing, that still counts. Okay, so you don't physically have to be able to say the words, you either need to be, but you need to be able to clearly communicate that it's your decision and it's your desire to have this. So communication, it doesn't matter which way it is, as long as you can do it. You do need to be able to ask though. It can't be, as I said, it can't be your loved ones that are asking on your behalf. The request needs to come from the person individually. And you need to be dying from something. So you need to actually have a terminal illness. You can't just request voluntary assisted dying for any particular reason. So there has to be something that's causing you to die. How the actual process, it's the other things. So I guess one of the big concerns that came from overseas was around life insurance and things like that, because a lot of people were concerned that it would be considered suicide and you might not be covered in different insurance policies and things. Voluntary assisted dying is not written onto a death certificate. So your cause of death would be due to your illness. It's not, and nowhere does it actually say voluntary assisted dying on any official paperwork. Once you start the process, there is absolutely no obligation to continue. So even if you get approved for voluntary assisted dying, does not mean you need to use it at all. So you choose when you actually want to do every single step of your process. And it is all at your pace, within reason, obviously. Health still has to jump through different hoops. And I think it sort of takes about 3 to 4 weeks from the beginning to the end to get approval. So once you initially say you want to access voluntary assisted dying, within 4 weeks it all should be approved and everything should be ready for you to do it. Once you have been approved, there is 2 different ways that voluntary assisted dying can happen. It can either be self-administration or it can be practitioner administration. So that means you can either take the medications for yourself in your own time and your own way, or you can have a practitioner administer them. It still gets done wherever you choose for it to happen within reason. So most people obviously would rather die at home. So practitioner, even the practitioner administered one, they will go into your home and they will do it there. You obviously can't choose to die at Bondi Beach at sunrise, because that would probably be distressing for everyone else who's at Bondi Beach at sunrise. But within reason, you are allowed to choose where it does happen. And as I said, it is all at your own pace. So as I said, so we went live. So this is, I just Googled it over the weekend to see what was happening. A lot of people actually start the process, and I think Victoria and Western Australia, it was about 50% of people who, when they were approved for voluntary assisted dying, never actually went through with it. So they actually died of their own, the disease process itself, as opposed to the actual voluntary assisted dying. And I think one of the benefits to this is that it gives you your own choice, and it sort of allows you to control your own disease process in some way. So everything in terms of medical is whatever happens, you have no control over it, you have no say. If you've got access to voluntary assisted dying, you know that you can end it at any time. If it's that pain and suffering that's what's concerning you the most, I think people who have got that ability to know that when that ends, they can end it, it gives them a lot more comfort. So they actually find that a lot of people who are approved for it don't actually then have to use it. They just die happily knowing they had that control. So you can see we went live officially November in last year. 517 people have applied for voluntary assisted dying. About 430 of those have been approved, but only 131 have actually completed that process in that time. So the numbers aren't necessarily huge, but I guess it's 131 people who have had a lot more peace of mind than probably would have had previously. And I think that's the whole purpose to the voluntary assisted dying, is that it does give you that comfort, it does allow you to end that suffering. And a lot of it is around that emotional suffering as much as it is the physical suffering for people with these diseases. I feel that I've gone through that very quickly. I thought I was talking slowly. No one told me to slow down. So, as I said, I think it's the approval for voluntary assisted dying that is the most comforting for a lot of people. Across the country, across the world, I should say, there are a lot of different rules around who can be eligible, how it's done, all different types of things. But I think just the whole thought that we have that and it is an option for people have made things a lot easier. But as I said, it is only your individual choice. Only the person who is in that, going through that disease themselves, can actually choose that they want to end their own life. And they don't have to tell everyone. So if they want to do it on their own, they're allowed to do it on their own. They can include as little or as many people as they want, and it is all their choice throughout the whole process. And a lot of our training when we do it is to look at the dynamics around the family to make sure that there isn't any pressure and to make sure that people are happy with that decision. And I think you'll find, and this probably comes up a lot in organ donation as well, there might be one member of the family who's not necessarily happy with that process, and we have to stop that from occurring, whereas voluntary assisted dying, it's the opposite. The family don't have to be happy with it. It's only the person who's requesting it that does actually have to be happy with it. And as I said, staff don't have to be part of the process, because whilst everyone works in healthcare, a lot of people in healthcare are there to help people get better and not necessarily to end people's lives, so they don't necessarily have to be a part of it. And I think that probably comes back to the actual administration part as well. You can, as I said, you can self-administer it, so there's oral medications that you can take, or you can actually ask for someone else to do that, because I think that's probably the hard part as well. If you choose to self-administer it, you physically have to be able to do it yourself. So you can't have a family member do that for you. So you physically have to be able to take the medications yourself. Otherwise, you need to get a practitioner to do that for you, and then they can help you to do that. And you can also choose to have it done in hospital. If you don't want to die at home with your family or with the family in the family home, you can go to hospital and have everyone in the hospital with you, and you can choose to do it in that way as well. And as I said, it is a potentially very triggering subject, so there is lots of people you can talk to, or because I've spoken too quickly, we've got plenty of time to talk now, if anyone has any questions.
Okay, Kylie, as a speech pathologist, I'm just interested, how is the medication administered if someone has swallowing difficulties?
So there's two options. So there is either oral tablets, which some of them are liquid, some of them are tablets, or there's an IV option. Yep, so you can have either choice. So if if they've got motor neuron disease and they've got swallowing options, there is IV choices as well. Yeah.
Generally, how long this whole process take from the initial application to the medical practitioner to the end? Is it different to different people, or is it?
So it's maximum of 4 weeks. So once you sort of ask that you want the process, they think it should be approved and everything done at the 4-week mark. Sometimes it can be quicker, other times it might be a little bit slower, but on average they're saying about 4 weeks. And then once they've approved you, if you choose to self-administer, they send the drugs to you, and so you've got them in the house, and then you choose to use them whenever you want. If you choose practitioner administered, they'll send the drugs to whichever practitioner is going to do it, and they'll keep it there until you're ready to access it.
Hi Kylie, once the medication has been administered, how long does it take to actually pass away?
Not long, it's like minutes. Right. Yeah. It's very painless, yep. So the first one, it's like a very big general anaesthetic, so you're not aware of most of it, yep.
I was just wondering, how different is this to end-of-life plan?
End-of-life pain or end-of-life planning?
End-of-life plan.
So I guess end-of-life planning is eligible for everyone, so everyone should think about how they want to die and what they want that to look like in terms of death, disability, that sort of thing, whereas this is only for a very small amount of people. So it tends to be people who have got cancer or who've got a motor neuron disease, so the majority of people won't be eligible for voluntary assisted dying. Yep. So whereas end-of-life care, it's if you've got an illness that you can't predict when you're going to actually die. So a lot of end-of-life care is managing symptoms as opposed to the actual death itself. No. Well, no, because you still have to be able to ask. So you have to be mentally alert enough to be able to ask that question. Yeah, so even at the end of your life for voluntary assisted dying, you have to, so whereas a lot of people sort of drift into unconsciousness or they get a bit confused, and so they're not then eligible. Yeah.
Hello, Kylie. I'm a bit concerned about the fact that you said that the medication is then sent to the house. And it's just lying there.
No, so there's a locked box. So it gets sent in a locked box, so only one person has access to that box, and they legally have to sign for it, and then there has to be a second person who's responsible for that medication. So we all get given a locked box where it gets kept in, so kids can't access it and stuff, for example, so you'd put it in a place where no one can get it, but then it's in like a little safe. Yep, so it's very secure. No, so it's not going through Australia Post. No. No, and that would depend. If you're in Sydney, you'd be expected to pick it up. If you live in rural areas, there are other ways to work it out.
Kylie, you haven't used the word euthanasia. Is that VAD, or voluntary assisted dying, the same as euthanasia?
Pretty much, yes. Yeah, it's just called voluntary assisted dying. That's what the legislation is, yeah.
Got one more question. Can it be advanced care directive? Someone can set up for in advance before can it be done like a will or advanced care directive?
So even if you wrote it into your advanced care directive, you still have to be physically able to ask for it. So the person who wants to access voluntary assisted dying has to have the mental capacity and physically be able to ask for it. So we wouldn't take it from documentation, because if the person isn't capable enough to ask that question, then they're not eligible for it. Yeah.
There's 2 questions online. So a follow-up to that one was, if you can't, say, communicate verbally, is there another method of communication you can use?
So any other form of communication is fine. So you can write it at the time, but you need to be doing it at the time. So it can't be something you've written previously. But yeah, if you talk to text, whatever your method of communication is, that does work, yes.
And the other online question was, can you ask for a priest to be present?
Yeah, you can. Anyone you want at all to be present can be present. Yeah. You could 100%. You can have a party. You can do whatever you want. You aren't allowed to eat before you have the medications, but everyone else around you could. You're actually not meant to have anything to eat or drink for a few hours before you take it, just in case you vomit.
If you were to drink, would that mean you lose capacity? Would they consider that losing?
No, I think it depends on how much you drink, Michelle. That's exactly right. No, it's the fact that you might vomit and then it wouldn't necessarily work taking the medications. Yeah.
In your initial talk, you talked about age being one of the components. Can you explain what that age is and why that would be in place?
So you have to be of 18 years of age, and that's because that's legally when you're allowed to make decisions. Yeah, so whilst you can consent, no. You have to have the legal ability to make that decision. So in terms of medical care, you can consent for things from, I think, the age of 14, but you can't consent to this until you're 18 because you've got to be legally.
So saying a child dying of cancer
No, they're not eligible.
and their parents couldn't?
No. No, so you have to be an adult to be able to access it, yeah. I actually don't know if there's kids allowed anywhere in the world.
No, that's okay.
Yeah. 18 is Australia-wide, yes. Yeah, so it's the same legislation everywhere. And that's because that's a legal thing. Kids can't make decisions for themselves under that age, yeah.
Anybody else have any questions?
Oh my God.
My question is, you said you can't eat or drink right before the medication gets given to you. Is that included for IV as well, or just the oral medication?
It's mostly for the oral medications, but it is because people do get sick with sort of general anaesthetic type medications, so it's less effective, obviously, if you're vomiting, and less pleasant for everyone involved. Yeah.
Is it the one medication that's administered to everybody, or is there a variety of medications used?
No, there's one. We're legally not allowed to mention the medications. There's 3 different medications that everyone gets, and it's the same medication, whether it's IV or oral. So but the dose changes from person to person. Yeah.
So if you are going to self-administer, you could actually go to Bondi Beach at dawn. No. Okay, you need to explain to me why.
So, no, because I guess if you're going to Bondi Beach to swim of a morning, you don't want to walk through someone who's dying next to you. Well, I think we're meant to respect everyone's beliefs, so that's including other people. So I guess there's nothing to stop you from doing it, but it's probably not great for the general public to go for their morning walk and see someone dead on the side of the road.
Well, anyone who doesn't want to see me partake of this does not need to come to the lighthouse at Port Macquarie. It won't actually be at dawn, it'll be at dusk, okay? So don't come then. I think that's outrageous, but never mind. Does anybody else have any questions of Kylie? No? Oh, yep, we have one more down there.
So can we donate organs after voluntary assisted dying?
You can actually, yes. So there are a few people who have actually, their request is to die and to donate their organs, so there is set up to do it. The only difference is obviously you have to have it at practitioner administered in the hospital. But yeah, so that has actually happened a couple of times. That's exactly right. But no, so if someone if they're eligible to donate their organs, so depending on the reason that they're dying, then yes, 100% you can have both. Yes, yeah, but you'd only have to go in at that time. Yeah, yep.
I guess one of the main reasons that I've asked Kylie to do this today is because one of my friend's dad is actually in the late stage of leukemia. And when the palliative care nurses came to speak with him about his options with the family there, this was actually raised. And although she's a nurse by background, she was actually quite distressed by it. So I guess one of the things we need to be prepared for as people who are partners of somebody or parents of somebody is that this is going to be something that's discussed if palliative care is involved in any way, shape or form.
Yeah, most certainly. And as I said, we can actually broach that conversation in New South Wales as part of an end-of-life discussion. So whilst we would offer palliative care, we can offer voluntary assisted dying if they think you would be eligible for it. So yeah, it's not yet routine, I don't think, in practice, but it will get to that point where it is. Yeah, for good reason, I think. Yeah.
It's not actually on VAD, but I think anybody that has access to death cafes, you're talking about people talking among your family, etc., because a lot of people don't talk. But if you can get to a death cafe, you sit down, you have a cup of muffin or something like that, and you don't have to talk. You can listen to what other people are talking, but if you want to talk, it's free. But it's just a pleasant way of talking about you, your feelings, and other people's.
No, most certainly. So I think it must have been palliative care week last week. So we had death cafes at the hospital last week. I mean, it sounds awful. I 100% acknowledge that, but it is. Every one of us are going to die at some point, so it is something that we should start having more conversations about. I didn't know death cafes were in the public. I might have to Google that. No. Oh, there you go. Oh.
Really? Wow. Has anybody been to a death cafe? Wow. Can I ask what's involved in a death cafe?
I think it's just general conversation around death and dying, yeah.
There's people that have just lost somebody. There's people that know somebody that's close to them. They've got a short lifespan. And my husband and I went. We at this stage, we don't know when we're now numbers up, but we didn't think we were going to talk. But my husband spoke about his sister and her husband, but one of the things he was talking about, the fact that her husband and herself, they didn't speak about it, they didn't cuddle each other, they didn't cry or anything like that, and he just felt that was strange. And the facilitator said, no, not really, because different people handle things different ways, and that's what they're trying to say. If you feel that way about it, and I don't, that doesn't mean either of us are right or wrong. You just handle it. But it's just, say, you go in, you have a cup of tea and have a biscuit or something like that, and it's, as I say, if you choose to speak, fine. If you don't want to speak, if you just want to listen, that's fine. I think I went to one down at, was it the Kiama or an hour, I'm not sure that part of the world anyway, and there was probably about 20 people there, and probably about half of us spoke. But
Topic for next year.
Topic for next year. Okay. Any further questions at all of Kylie? Okay. So thanks very much, Kylie. I have to say that was incredible, quite frankly. Because we all know they're out there, don't we? There's voluntary assisted dying laws, but I don't know about any of you, but I did not know the detail of them. And I have to say I think Kylie did an exceptional job bringing out the detail and why they're there and how we go about it. Oh, the clicker. She needs a clicker. So again, I'd like to reiterate that talking about death and dying can often be quite triggering to people, particularly people with stroke, because if anything brings you up and close to your mortality, it is stroke. So just be prepared if any of you want to talk at any time during the day. Kylie's around, I'm around, and the staff are around as well. So feel free to approach us if you're feeling upset or distressed at any time. And if you do go home and you're feeling upset or distressed, don't forget those lines that are available as well. And she didn't put our line up there, which is the 1300 650 594 line, but I'm quite happy to chat to people about death and dying at any time. It's a topic I do like to talk about because I think it's important in anybody's family that everybody knows what our wishes are. Because if they don't know what our wishes are, then what are they going to do when we suddenly, and often we do suddenly pass away?